high rates of diabetes, high rates of obesity, okay, as well as Latinos and blacks, yet again. Okay? What we tend to find, okay, are among the highest rates of infant mortality in a developed country. Okay? So, in just about every which way, we see differences by racial and ethnic lines. Okay? In order to just give you a flavor for what we have, I'm just going to pick a couple of examples and show you a couple of graphs. Okay? It's going to stick. Okay. So, starting off at the beginning, and if you're interested in this material, a documentary that would be worthwhile to consider is called Unnatural Causes. It's free, it's on the internet, and it goes through a series of conditions and a series of places wherein there are racial ethnic disparities and understanding why there are racial ethnic disparities, as well as income disparities. Okay? Now, what am I talking about when I talk about infant health? Okay? What we find in terms of infant health is that there are racial ethnic differences in terms of preterm delivery, okay, or delivery up to term, in terms of birth weight, okay, so individuals or children who are born less than 5.5 grams, okay, and sometimes less than 2.5 grams, okay, for both there are big disparities, and also mortality, okay, so the likelihood of death within the first month of life. We are not born equal, okay. What we find is that there are disparities wherein African American, American Indian, Native American individuals tend to have extremely high rates of, for example, on this graph, infant mortality. Okay? What is worthwhile to consider is that when you put income into the play, or when you adjust for education, when you adjust for income, the differences across race increase. So what we actually find is that a college-educated black mother is more likely to give birth preterm than a high school, non-Hispanic white who's high school educated. I will note here that preterm delivery is directly correlated with birth weight, and birth weight is a high predictor of mortality. Okay, so these all overlap, and it's worthwhile to consider what is happening. Okay? Something also worthwhile to note here is that in King County, these disparities exist. So this is not just a nationwide problem, it's a local problem. Okay? Locally, what we find in King County, okay, is that black and Indian mothers are 2 times more likely, or over 2 more times more likely to give birth earlier, okay, and to have higher rates of infant mortality in this county. Okay? What's also worthwhile to consider, okay, is that infant health translates into vulnerability as an adult. Okay, so individuals who are born as preemies, okay, tend to be host or vulnerable to a number of adult health outcomes or health conditions. Okay? They also tend to be more likely to give birth or have preemie babies as well. Okay? Now, what about adult chronic conditions? Okay? Are there disparities in terms of adult chronic conditions? Well, what we find, just giving you a sampling, okay, is that the obesity epidemic, okay, wherein 30% of our population in the United States across lines, okay, can be classified as overweight or obese. Okay? What we find is that racial ethnic minorities tend to be more likely to be at risk for overweight and obese status. They tend to be more likely to be overweight and obese. They tend to be more likely to have type 2 diabetes. Okay? They tend to be more likely to have cardiovascular disease or heart disease or high blood pressure. They tend to be more likely to have cholesterol problems. Okay? It's worthwhile to consider, okay, that this isn't the case not only of having a condition, okay, but also what happens when you have that condition. Okay? So, for example, in terms of this graph right here, what we find, okay, is that people of color are more likely to die of diabetes. People of color are more likely to have uncontrolled diabetes. If we think about this in terms of hypertension or high blood pressure, okay? I'm not sure how many of you are aware of this, but CVD, or cardiovascular disease or heart disease, is the #1 killer in this country. It's a silent killer. And what's worthwhile to consider is that there are dramatic differences as to who has it and who's more likely to die of it. Okay? What's also worthwhile to consider is that cardiovascular health directly pertains to stroke, directly pertains to Alzheimer's, okay? All of which there are racial ethnic differences. So is race and health, is that a worthy discussion to have? Okay? It's worthwhile to note here that racial ethnic populations or racial ethnic minorities or people of color vary as well in terms of subpopulations. Okay? So, for example, whereas Black, Puerto Rican, and Dominican Americans tend to be more likely to be at risk for having high blood pressure, Mexican Americans have the same amount or the same level of risk, and yet they're less likely to be aware of it, they're less likely to be controlled of it, and they're more likely to die from it, they're more likely to have complications. So it's not only a matter of having a greater risk of having a disease, it's when you have the disease, what is the level of it affecting your daily activities, your ability to perform daily things, or to do what you have to do on an everyday basis, okay? And what level of it, or how does it affect your quality of life? Okay? Now, let's give an example in terms of outcomes, okay? Let's look at it in terms of cancer, okay? Now, here's a percentage, and I apologize already for the tables and the graphs that are really far on the ground, okay? What we tend to find, okay, in terms of breast cancer, is that non-Hispanic whites are more likely to have breast cancer than Blacks, whites, and Asians, and Pacific Islanders, and American Indians, and Native Americans, okay? What's also worthwhile to consider is that despite having greater risk, people who are more likely to die of breast cancer are Black women. Okay? What we also know is that in terms of 5-year survival rates, what we know, okay, is that Blacks and Latina women are less likely to survive up to 5 years out. And that difference increases 10 years out. Okay? And for the women who survive breast cancer, what we tend to find, okay, is that there are racial ethnic differences in terms of quality of life. Okay, so what do I mean by quality of life? What I mean by quality of life is really, okay, what I mean is your ability to rely on your social network, the social support that you were able to reach out onto, okay? The day-to-day activities, doing your laundry, getting your wash clothes, being able to drive to work, being able to walk, okay? Being able to lift things on your own, okay? Feeling emotionally well, not having anxiety issues, not having depressive issues, okay? Something that is a robust disparity that we find among survivors is that among survivors, Spanish-speaking Latinos specifically tend to have the worst emotional distress after they've survived. So they're alive, and yet they're experiencing very high rates of mental health problems. Okay? This is just a flavor of a couple of reasons why perhaps there's evidence that 1, we should care about race and health, and 2, we should really be thinking about the health of racial minorities or of people of color. Okay? Now, because there's possibly an issue, okay? Possibly I've given you some evidence that there are health disparities, that there are conditions for which we should be concerned for racial ethnic minorities, okay? It's worthwhile to consider what are the factors. What is causing these differences? Why are there differences across racial ethnic lines? Especially considering that there is no genetic basis for race or ethnicity that we are aware of. There's no race-specific allele. There's no race-specific gene, okay? The fact that we know that the definition of race has changed multiple times, okay? So for example, the Irish were considered a separate race from Englishmen, and were considered the missing link between the Englishman and the African man. Okay? So varying definitions of race, no genetic basis. So what is happening, and what is the potential role for racism, okay? What do we know about racism, and how is it possibly associated with people of color being more likely to have certain diseases, as well as more likely to suffer from when having certain diseases? Okay? What are possible ways? Okay? Before I give you a structure, or before I give you my structure, my perspective, what I would like to do is really quickly open the room and just have a brief discussion concerning what racism means, what it sounds like, how people understand it. Now, I would like everybody who has a heart, whether it be a heart condition or not, but has a heart, has a beating heart, to raise their hands. If you have a beating heart, raise your hands. Okay. Let's please be aware that everybody's. Let's be aware that everybody has beating hearts, or most of us have beating hearts, and we don't need them to beat any faster because we feel disrespected. Okay. So everybody's respect. Everybody's adequate. Okay. And we're not talking necessarily what you believe or what you endorse, but what comes up, or what comes to mind when you hear the word racism?
Shout out.
Yeah.
Power differences.
Our differences?
Segregation.
Segregation? Superior? Superiority? Okay.
History.
History? Okay, that's good. Thank you.
Classification.
Entry?
Classification.
Classification?
Stereotypes.
Stereotypes?
Oppression.
Oh, wow. Let's have both of those volunteer again.
Oppression.
Oppression? Prejudice? Institutionalist? Okay, this is all worthwhile, all right? If you saw the flyer for today, what you will notice is that the perspective in which we understand racism academically and from a scholarly perspective is to really think about it in terms of a systemic problem that leads to socialization at the individual level, okay? Or in other words, a system or a set of standard practices, standard care, standard norms, okay, that potentially influence individuals who are experiencing that context, okay? Now, what is worthwhile to consider, what I'm not gonna have any time for because I'm already 14 minutes close to done, okay, is to think about the context of systemic racism and to think about how it may impact people's attitudes towards themselves as well as towards other people. Again, if you're interested in this, next fall, I'm teaching a class on the psych of racism. And if you're transferring to UW, I'm going to be teaching it in the spring, if you're interested. Okay. Now, just for the purpose, do you like how I plug everything? People are interested as well. If you're interested in any of the materials that I give you in this talk, if you want to read up the actual papers, I would love to. Okay. Now, let's think about a framework by which we can understand racism and health. Okay. When thinking about racism and thinking about it in terms of a systemic issue or something that has a systemic level, what we are talking about are racial ethnic inequities, right? Or in other words, what are systems that are in place, standards that are in place wherein racial ethnic minorities, wherein marginalized groups are experiencing a very different perspective, a very different life, okay, in the United States relative to non-Hispanic whites, okay? What's also worthwhile to consider here is that this issue and this framework is not US based only, okay? So these problems and this relationship between racism and health has been studied in Australia, okay? It's been studied in Brazil, it's been studied in China, it's been studied in England, okay? It's been studied in Russia, okay? It's worthwhile to note, okay, how spread this can be, okay? So what I want you to be thinking about, and this is the framework we're going to try to use, okay, is thinking about institutional inequities, okay? Experiences or places wherein racial ethnic minorities differ, okay? We're thinking about it in terms of class and social income, or socioeconomic status and income. We're talking about it in terms of neighborhood effects, okay? And then healthcare. What we're going to relate is looking at how these differences pertain to health outcomes, okay? And then if we have time, we'll get into perceived racial ethnic discrimination and how that relates to outcomes as well, okay? Now, more often than not, whenever racial ethnic disparities come into play, an obvious question to ask is it only a matter of income? Okay? In other words, it's a matter of poverty. What we know about health, okay, is that health is where you live. Place matters. Okay? Health is also not just a product of your attendance in a hospital or a healthcare system, but a matter of everything in your daily life. Your body reflects everything that you're experiencing, from stress to food to exercise. Stress is there, coping is there, personality is there, and that's going to impact your physical health and well-being. Okay? Now, given that we know that income is one of the largest, one of the strongest predictors of health, where poor people tend to be more likely to have chronic conditions, more likely to suffer when they are diagnosed, okay, with a chronic conditions, can we think of racial ethnic differences as a matter of class, as a matter of money? Okay? It's worthwhile to consider that. For example, in 2006, okay, what we find are that racial ethnic minorities tend to be more likely to be represented in poverty ranks, okay? Or in other words, the average income or average amount of money tends to be lower among racial ethnic minorities. It's also worthwhile to consider that while I'm focusing predominantly on Black and Latino populations, as well as a little bit with Native Americans, among Asian and Pacific Islanders, for example, what we find is that the populations or the ethnic groups that are the poorest also tend to have the poorest health, okay? So for example, Hawaiian mothers tend to have higher rates of infant mortality than any other group other than Blacks in the United States, okay? It's worthwhile to consider that poverty seems to be potentially influencing what happens, okay? Now, okay, so if we adjust for income, do we actually find that there are still racial ethnic differences that exist. Okay? It's worthwhile to consider that this is a problem that is now really being focused on. Okay? What is the intersection? Okay? Because there is impact in terms of income and wealth, and then there's an impact in terms of being a racial ethnic minority or being somebody who's a person of color. Okay? What's worthwhile to consider here is that when you stratify, so when you look at only low-income people, you only look at mid-income people, you only look at high-income people, okay? What do we find? We find that the percentage of individuals who are reporting poor health tends to decrease. Health is wealth, okay? Or as the famous quote is, the best wealth is health, okay? Now, what is interesting here, okay? If you look at these bars, okay? So these are non-Hispanic whites, these are Latinos, these are African Americans. Across the board, what you find that is that across income levels, the proportion of individuals who are self-reporting poorer health, who are black, is higher than the proportion of non-Hispanic whites who are reporting poorer health. Okay? What you find is that as wealth increases, health does not increase as much for blacks and for Latinos as it does for whites. Okay? One question to ask is why? Okay? It's also worthwhile to consider, like I was saying before, in terms of, for example, infant mortality. What we find among high-income women, okay, is that the difference between the likelihood of higher preterm birth increases for black women being particularly at risk, okay, as income increases or as income is adjusted. Okay? What we find is the same kind of issues in terms of asthma, okay, for example. So why is that? Okay? What is one potential way in which we can understand poverty? Or why is poverty, or why is the effect on poverty, on health, not equivalent? Okay? Or why is it not the same? Now, I'm going to give you some stats. I'm running out of time. Scheiße. And I just want you to sit with them, ponder them, and then we'll maybe talk about them as we open up the room for discussion. Okay? What we know, if you're interested in this, Doug Massey is the one to go to. Okay? M-A-S-S-D-Y. Okay? Is that the most affluent black Americans, people making over $50,000 a year, tend to be more segregated or tend to be less likely to live in predominantly non-Hispanic white neighborhoods than the poorest Asians and the poorest Latinos. What we tend to see is that, for example, individuals who are middle-income African Americans tend to live in poorer neighborhoods, so neighborhood income being poorer, than individuals who have the same individual income who are white. Okay? It's worthwhile to consider, is poverty and how poverty impacts health, is that somehow related to segregation? Is that somehow related to the type of neighborhood where you live? Okay? Now, here is a graph that perhaps shows a little bit of information in terms of whether segregation may or may not be a problem in the United States. Okay? So this is the level of segregation that we see in South Africa in 1991, okay, after the official apartheid. And this is what we see in 2001 across different states or different cities in the United States, and then overall in terms of the US. Okay? What we know is that segregation happens in every major city. What's worthwhile to consider as well is that there is no city currently, to date, my data analysis being from 2011, so something might have changed this year. Okay? What we know is that there is no city wherein African Americans live in the same type of neighborhoods with the same amount of money as non-Hispanic whites. Okay? Now, is this a problem in Seattle? Does King County possibly have some issue in terms of segregation? Okay, so what maps I'm showing you right now are two maps from King County from 2000, so things may have yet again drastically changed in the last 10 years. Okay? What we find is that this is where non-Hispanic whites live. The darker the color, the more non-Hispanic whites who live in that neighborhood. And this is where African Americans live. Okay, the darker the color, the greater proportion of non-Hispanic blacks that live in that area. Okay, so if segregation is not an issue, these should be similarly colored. There should be no mirror effect. Look where the darker shading counties are in each area. Okay, is segregation possibly something that we need to be considering here?
Yes.
Okay. Just think about it. Emphasize. Okay. Now, set that I'm going to go through really quick. Okay? There are a number of studies that show that racial ethnic minorities, and especially blacks who are hyper-segregated, okay, tend to live in poorer neighborhoods. Okay? So this is a study looking at African Americans living in urban areas, European Americans living in urban areas, and European Americans living in rural areas. Rural areas being rural populations experiencing poverty as well. Okay? What we tend to find is that the average amount of poverty wherein African Americans live, okay, tends to be higher. Okay? And the amount of poverty tends to be higher where African Americans are relative to European Americans, regardless of whether they live in urban or rural areas. Okay? Now, what does that mean in terms of health? When you do some fancy math, okay, and when you account for neighborhood income, what you find is that racial ethnic disparities disappear for these outcomes. In other words, individual income does not account for some of the differences that we find that neighborhood income does, neighborhood poverty does. Okay, it doesn't account for all of it, it doesn't account for all of heart disease, but it accounts for a good proportion of illness. Now, why is that? Why would neighborhood poverty have anything to do with health versus individual income? Okay? Think about where you live, and now think about your daily routines. Okay? Think about it in terms of, for example, health behaviors. Okay? Well, we know in terms of exercise, people are more likely to exercise within their own neighborhoods. It's worthwhile to consider. Racial ethnic minority neighborhoods have fewer parks that are considered safe to exercise. They have fewer gyms. Okay? They have higher rates or higher costs to get gym memberships. What we know, okay, is that in terms of food, right, there's a drastic difference across income as well as racial ethnic lines. Okay? I don't know how many of you are aware of the term food deserts, but if you're interested in food, that would be a good word to use in Google. Okay? What we tend to find are that there are these food deserts where there are fewer grocery stores. There are grocery stores with lower quality food. There are food stores with a poverty tax, okay, wherein food is actually higher priced in low-income neighborhoods. What we tend to find is that even within those neighborhoods, it takes longer to get to a grocery store than it is to a convenience store and to a bodega, for example, to places that are of convenience, which may not have the highest quality foods. Okay? How might that perhaps affect dietary choices? How might that affect diet? How might that affect obesity risk? Just think about it for 1 second maybe. Okay? Think about where you live and where are your resources. Okay? And how long does it take to get certain food? How quick is it? Okay? Now, those are two issues. There's also environmental hazards. If you're interested in terms of environmental toxins, okay, a good phrase to use is environmental justice or environmental racism. Okay? What we tend to see, okay, is that people of color, and a lot of this, I will put a stringent amount on, a lot of it has been studied in terms of Houston, Texas, the South, and I guess Texas is the South, and California. Okay, so a lot of this has been studied in these areas. What we tend to find, okay, is when we're looking at the distance to production waste, when we're looking at the places where the dump sites are, where toxic waste is, the more or the greater proportion of African Americans, the greater proportion of Asian Americans, the greater proportion of Hispanics that live in a neighborhood, the closer they are to these sites. If you're really interested in some good case studies, I would Google Cancer Alley in Louisiana. Okay. Now, why is this possibly going to impact health? Okay, so think about this in terms of neighborhoods. Okay, we think about it in terms of segregation, we think about it in terms of resources. Think about it in terms of food stores, exercise stores, think about it in terms of environmental toxins. Okay, now let's think about it in terms of, since we're talking about health, health services. It's worthwhile to consider that the types of hospitals that are in racial ethnic minority neighborhoods that have higher mortality rates, tend to be more likely to close. Okay, that pharmacies tend to be less adequately equipped in racial ethnic minority neighborhoods. And you can see this across the board in terms of the 4 ethnic groups. Okay? What we're talking about specifically is pain medicine, okay, and opioids. Now think about it and think about stereotypes concerning pain medicine and who gets addicted to pain medicine and who gets addicted to opioids. Is possibly there an interaction there? Okay? It's worthwhile to note as well, in terms of healthcare, what we tend to find, okay, is that there are both between hospital effects as well as within hospital effects. Okay? Between hospital effects being people going to different types of hospitals and different places of care, okay? And because they're going to different places of care and that place of care is not adequately filled or adequately equipped, okay, it leads to poorer health. So there's some evidence of that. For example, like I was saying before, non-Hispanic whites tend to be more likely to be diagnosed with breast cancer, to be less likely to die from it. It's worthwhile to consider both Black and Latinas more likely to get detected or get late-stage detection. Okay, or have larger tumors upon diagnosis. Worthwhile to consider, that is mediated purely by what place or where they go to get mammography services. Okay? And the adequacy and how much time it takes to get there. Okay? So, there are between hospital effects in terms of where you go and where you go being able to satisfy or give high quality care. There's also worthwhile within hospital effects. Okay? You compare blacks and whites on the same insurance plan when you compare them within the same hospitals. Okay? There's going to be longer waiting times, shorter visits. Okay? There also tends to be disparities or differences in terms of communication. Okay? There tends to be more verbal domination, okay, or more physicians talking for a longer period of time, okay, in visits with African American and Latino populations. It's also worthwhile to consider that I've not put this on, but of all individuals reporting quality of care, what we really know is the people reporting the worst quality of care are actually Asian Americans and Pacific Islanders. Okay, a lot of it being linguistic barriers, but also even when you account for interpreters. Okay, there is a difference. Is this worth considering? Okay, these are systemic differences. Now, last slide, and we're going to open it up. Okay, so we have these systemic issues. If we get rid of systemic issues, do we get rid of health problems? Okay, or in other words, what about everyday discrimination? Okay. What we tend to find, and if you're interested in this, I would Google David R. Williams. There's a bunch of review articles that are worthwhile to consider. Now, think about this in terms of what has to happen for racism to potentially impact health. Okay? There's a discriminatory event, but for that discriminatory event to impact health, the person has to figure out that it is racism, or has to wonder whether it is or is not racism, okay? And then has to respond to it, okay? So how you cope with what you believe to be racism and how you think of racism, okay, impacts potentially your stress pathways, okay? And what we know in terms of both income as well as racial ethnic identity, as well as sexual orientation identity, as well as gender identity, is for all of that to impact health, it has to influence how you're thinking about the situation you're in. It's worthwhile to note that there is some evidence to suggest that very blatant discriminatory events are not as harmful as events that are ambiguous, situations where you're not sure if you've been discriminated against or not. You are a credit to your race. You're so intelligent. For example, I know you're really good at math. I know your people are. Okay. Where are you from? What are you? If you're interested in these types of questions and these types of statements and how they impact health, microaggressions, Google microaggressions, I'll get to you. Okay? Now, where I keep blabbering at you, what has it been correlated with? Okay? So people who report receive discrimination, how is that associated with their health? Well, we tend to find, okay? And this was done in Detroit, okay? And what they did was a longitudinal study. They studied 1996 versus 2001. Okay? Individuals reporting greater amounts of discrimination tended to have poor self-health 5 years later. Okay? It's a correlate, but it's an interesting association. Okay? Thinking about it in terms of stress, what is that person experiencing? We also tend to find in terms of physical health outcomes. Okay? More often than not, a lot of racism and work on individual level racial discrimination has been focused on mental health. The second place where it's been really studied is surprise. Is blood pressure.
Did you want it on?
It's okay. We'll open it up. Is blood pressure. What's interesting to note here is that the relationship between Okay. What's interesting to note here in terms of discrimination is that actually individuals who tend to do worse are individuals who are reporting no discrimination whatsoever, and individuals who are reporting a lot of discrimination whatsoever. So why possibly is that? Open up for discussion. Okay. It's interesting to note as well that obesity is also correlated with discrimination, even after you account for years in the United States. So people who spend a longer time in the United States experience more and more discrimination, and this is with Chinese, individuals who are Chinese born. Okay? What we tend to find is that obesity is associated with the more discrimination that you've had. Okay? It's also interesting to note that it's related, or has been correlated with diabetes factors, with breast cancer, as well as preterm delivery. What's worthwhile to note in terms of preterm delivery is that they've done studies where they've accounted for pregnancy stress, for general stress, for every other type of stress. And racism, lifetime experiences with racism, predict preterm delivery when you account for all of that and income. Just blabbered at you 30 minutes, I want to say. So I know I gave you a little information. What I would like to do now is put it up in the last 25 minutes that we have, okay? And maybe get your immediate reactions, questions, comments, whatever it is.
You talk about Cancer Alley, the Community Coalition for Environmental Justice here in Seattle and the Northwest, and also the Environmental Protection Agency have made maps of Seattle where South Park and the Rainier Valley are most likely to be, well, have toxic waste dumps and toxic waste that is produced by industries in those communities. And notice that that's where a lot of people of color live.
Do you think that this the whole racism connection to health, do you think that it is stemmed from history? I see it a lot, even I studied the achievement gap and the differences between white and minority students and students that lived in lower income poverty, and even the people that, even the minority children that lived in white neighborhoods still didn't do as well in school as the white people. So do you think that do you think history has a role? Do you think do you think it's a cycle?
Absolutely. So, thank you for that. History has a profound role in health, and it's just starting to be studied. There's some work mostly with Native Americans, American Indians. Karina Walters, who's here in Seattle, has been looking at it in terms of intergenerational trauma and sort of the history of being displaced, the history of genocide in your tribes. And what we tend to find are, for example, tribes who come from populations that from First Nations that have been extremely marginalized and all that, they tend to have poor outcomes and poor health than nations who are not as impacted. Okay? In terms of African Americans, there's this term called post-slavery
Traumatic slave syndrome.
post-traumatic slave syndrome. Thank you. Okay, which is also associated with health and also associated with what's happened as a consequence. It's also worthwhile to note that in addition to history, in addition to how your parents act and your parents' health being transmitted to you in terms of their stress hormones, their stress levels, and that's impacted you as a child, what you also have to consider is that cultural norms are also impacted. Okay? So, for example, what we know is that for all three groups that I'm thinking about, which are Asian, Latino, and Blacks, okay, what we find is that there's greater patient distrust. Okay? And you can think about it in terms of historical traumas in healthcare systems, such as the Tuskegee experiment. Okay? Right? And situations wherein there's been trauma, or there's been, for example, even a helicopter effect, where people go in, they study your research, they study your health in your community, and then they fly out, and the money flies out with them. Okay? Hopefully that answered your question.
I remember hearing something on the radio, NPR I think it was, about how outcomes for whites and outcomes for blacks who've had strokes are different because for some reason white patients get some sort of a medication that helps to avert some of the post-stroke problems that happen, whereas black patients are less likely to get that medication. Do you have any information about things like that?
I do have information on things like that. Thank you. I was going to say I don't have information in terms of stroke, but we know that they have differences in terms of heart medication, in terms of medication for HIV and AIDS, for people living in the obsolete, but the most innovative medicines tend to be less likely to prescribe to patients with therapies.
Why?
What we also can suggest, or we can think about, is that going back sort of in terms of thinking about things as systems and as society and as context, okay? There's a lot of conversation in terms of physicians, professionals, individuals who are born and raised in countries wherein there's a lot of segregation, there's a lot of stereotypes, there's a lot of information that's being given, right? And so as a consequence of being an individual who's living in that society, okay, physicians may potentially develop certain implicit or unconscious biases, right? And so there's been some work in terms of, how many people are aware of the implicit association test? Okay. I would Google the implicit association test. It's a really good measure in terms of unconscious attitudes, and it's been used for fat phobia, it's been used for homophobia, gender, as well as race. It started off this, it blew up with race, okay? And what we tend to find is that there are these unconscious associations with, specifically with physicians, wherein physicians are unconsciously, they're not conscious of this, they're doing a rapid, quick psych test, okay? They tend to be more likely to associate blacks as having poor dietary choices, as being less compliant as other patients. So medical compliance. So there are these unconscious biases, they're not thinking about this consciously. Okay, but when they're doing a quick test rapidly, and if you're interested in that, I can show you how it happens and how it works later. Okay, but tends to be this association of this bit. It's also worthwhile to consider that gender also plays a factor. So the physician's gender can also impact the likelihood of the type of treatment they give by patient race, ethnicity, wherein women tend to be, racial ethnic differences tend to be greater with male doctors.
I'm wondering if you could speak to maybe kind of a health psych or social psych solutions for this, and then also at the individual level. So how do we change this?
So perhaps some of this stuff has been alarming, so thank you, Crystal, for giving some information as to what can we do, right? It's worthwhile to consider that there are several public health and community-based interventions to sort of deal with specifically healthcare. Okay, how to improve healthcare, getting lay health workers, getting people from the communities to help people navigate through systems. Okay, so if you're interested in that type of work, see me afterward. There's always something to be done in terms of whatever you want to pursue. Okay, so lay navigators, educating ourselves. Okay, in terms of how to deal with healthcare, how to advocate for yourself, advocate for your family members. Okay, there is some work, for example, South Park actually. Had or acquired funds in order to redevelop and redesign their neighborhood, being low income, and their impact and their ability to get those funds from the federal government to mobilize and work together actually helped reduce asthma rates and lead poisoning rates in this area. They're actually the success story. If you're interested in more information about that, Unnatural Causes covers it pretty well. Okay, so there's that level in terms of decreasing disparities at the systems level. Also, some work has been done, like I was saying before, blood pressure, it tends to depend on coping style. Okay? So some ideas in terms of coping or ways to deal with individual level discrimination, maybe to think about in terms of what types of coping strategies are effective in buffering you. Okay? We know, for example, that social support is one of the strongest medicines that we have. Okay? And people who are socially isolated tend to have poor health. Conversely, social support tends to buffer impacts of racism, of discrimination in general, tends to buffer or help, if you will, in a lot of ways, symptoms from manifesting. So people who have more social support tend to do better when they're ill.
Well, I'm a biology and chemistry student, and as a individual, we are different. For example, descendant of from Africa, Americans, people from Africa, descendant Africans, tend to have sickle cell anemia, right? So their red blood cell is shaped differently. So they are resistant to malaria, but they have sickle cell, have a problem in the oxygen. So in those, based on those genetic changes, we cannot take exactly the same medicine because how it's set affected specific area. So I was watching the Dr. House, the show. Then one of the episodes that the African American man come and ask him to prescribe a medicine, and the prescribed medicine, and he was very upset. Patient was very upset, and prescribe me this medicine because I'm African American. I want you to prescribe medicine that white people take. So he did, and then this other guy, African American doctor, come in very upset. Why are you trying to kill him because he's black? And Dr. Howe said, no, I wrote the medicine that African American man take. I didn't write the medicine for white man, medicine for him. So he just has no.
Yeah. And
I think it's stereotype. This is just really stereotyping.
Yeah, absolutely. There's stereotypes, and it's worthwhile to bring in genetics and what role do genetics play.
I think no physician wants to kill cause the patients. So.
And what's worthwhile, I will let you go. Do you want to talk first? But I want to just clarify that sickle cell and the sickle cell malaria bit is actually not just Africa. It's actually Africa, Middle East, India, and just about everything. And if you actually map on genetic composition, sickle cell and malaria, you find that sickle cell and how that's associated and how that's prevalent, the proportions of it, is directly associated with malaria. So areas with a lot of malaria, for example, India, also have high rates of it also. Just wanted to clarify that. No, we work together.
Yeah. So it's kind of dominant in genetics, that dominant allele. So whoever descendant is.
What's worthwhile to consider, though?
75% of Canada.
And what's worthwhile to consider for some of these outcomes, for example, is that African-born immigrants actually have the same rates of preterm delivery, the same rates of infant mortality as non-Hispanic whites. It's African Americans, and it happens one generation out. What we also know in terms of hypertension, high blood pressure, and cardiovascular disease is that the rates and the prevalence does not match African continents or African populations. Okay. So it's worth, but there are some genomic aspects and there are some genetic aspects. What's interesting is that for a lot of these outcomes, when we compare them to countries of origin or continents of origin, there's a difference. And actually there's a really fascinating thing called the Hispanic Paradox, wherein people who migrate to the United States tend to be better off than the kids who are born in the United States. The longer time you spend in the United States, the more sick you become.
So, lack of education or not knowing about these health issues plays an issue. A lot of people in these in poverty or some of the people dealing with, I mean, I wasn't even aware of all of the differences for the health issues. How do we get this information out? They knew the proper medicine that they were supposed to take or what was supposed to be given to them, or if they knew even about their condition or what they could suffer from. But a lot of people don't.
Yeah, great.
How do we get this information out, or what is the best way to go about this? Because they're not informed.
Yeah, I agree. So information, education, knowledge is extremely important. And figuring out how to get that information out there is really important in layman's terms or in common language, ways that people can understand. Okay, so a lot of the work that I do is with low-income populations. There's definitely an income effect in terms of the poorer you are, the less sure you are, for example, as to why you're getting asked to come back after an abnormal mammogram. The more likely you are to think that it's cancer automatically, right? When it's probably not. But because you don't have that knowledge base, you don't have that education base, you have no idea, you freak out, it causes a lot of stress, it causes a lot of distress, right? So how do we get that out there? One opportunity is getting community members, getting key leaders in communities to work with researchers to figure out how to make something that's sustainable education program, word of mouth, really figuring out how to implement social networks and connections. There's a lot of work that has been done within Black communities in terms of using barbershops and churches to get involved with health, for example. So the Witness Project is a really good example of African American communities in the East Coast who basically have a network now of churches and preachers and preachers' wives that are working together to talk about breast health, both awareness, knowledge, when to get mammograms, how to navigate, things like that. And it's spreading around, and there are some examples of it in Oregon as well as California, right? So it's educating ourselves and figuring out how we can get it out there and how we can connect with one another using the resilience and the resources that we have, okay, in each community. Because each community is blessed with a certain amount of resources and a certain way to communicate.
You said that neighborhood have played a big role. So if we could
integrate our neighborhoods more than you think the problem is addressing?
I leave the hypothesis out to all of you. I would say that in terms of segregation and integration, it's worthwhile to consider that you may live next to someone, but if you don't know that someone, it may lead to certain someone's being displaced eventually. And it's worthwhile to consider what true integration might mean. Thank you.
It is 12:50, and I know we all want to hear more, and if you are able to take Yamille's class, which I hope you are, I'm hoping she'll also come back in the future to more of our conversations on social issues. I thank you all for coming today, and please give a big thank you.
told me you were down there for a little bit. Yeah. Beautiful. Wow. For the holiday. Oh, what? For what? Oh, is that why you're going to go home? Really? Do you think that's really going to happen? No. Do you really think that? Really? Honestly? Okay. What leads you to I know that. And how does that relate to that?
Maybe if something happened that day, not the time. I just believe someone will happen. The whole world will be proud and I saw a video the revelation person this century. She talks about there will be some natural disaster happen and the world will be for some days. There will be a lot of and this century is emotional century and this century will be split back.
Well, that's interesting. Yeah,
I thought you were believe that.
no, I don't believe that. No, I don't believe that. I am indeed, but I don't believe in the destruction of the end of, or I don't believe in the external force that's here to destroy the planet or humanity. You know?
I don't believe in destroying that. It will move on to the next spiritual century.
I think that it's really important for us to raise our consciousness and raise our awareness and the life and animals and those things and beings in the universe and to treat each other with compassion. This is critical if we're to, especially in the 21st century when we're at perhaps like never before have we not destroyed it, but destroyed it. But that being said, that's it's not going to happen like that. Either the transformation or the raising of consciousness for more spiritual, more understanding, more compassion. I mean, that's part of a long process. And it's been 10,000 years it's been offered, so.
Did you not miss me? They're terrified of us.
Yeah, I mean, we could do a project.
I'm just kind of looking for
I'm so sorry, I was just like, I still seeing
Well, that's very interesting. I think it's a good idea to go home then.
That's
Good.
now, that doesn't
No matter what happens, if it happens, well, that's great, I'm home.
Sure.
If it doesn't work out, that's great, I'm
Good,
back.
good. Well, that's a good idea. Right. Well, it's nice to see you.
Yeah, that's it.
Yeah, good.
I love it. It looks like
Yeah,
she's packed up, so
yeah.
let's go forever.
With which?
Emotion.
When? You are? Right now? What's happening? Mhm.
I can make it happen. I cannot.
No, probably not, but,
So how do you handle that when you have a whole
love.
semester
Yeah,
quarter?
kinda.
Do you go into that? How do you handle it?
So I go to, so when I
It helps to have friends, some support. Do you have support group? Some friends? Or one
Yes.
friend?
It's sort of.
Yeah, that's not gonna help you.
Isolated myself.
Yeah, I'm sure, self-imposed isolation.
That was like my favorite.
Yeah,
Let me
well,
tell you my favorite.
you may wanna think
part
about
of this
opening
whole
yourself up to
thing.
a friend or two.
That
and
was
you
my
can talk to them
favorite
about it.
part.
It really depends on
Because that was,
Of course it
high-end way
does.
of,
So choose wisely,
you know, that was
but
really helpful.
it really helps to have
Yeah,
support.
we're always learning from each other. That's the thing I
It's
like.
important to know that you're not alone.
So, yeah, okay, so in your longer
And
class.
without knowing exactly what it is, that it's matters of love and
And I mean,
heart,
it's funny because
know that
focus on health, but it's only one of the outcomes.
it's good to be, to
I
sit
do a lot
with
in
it,
terms of education.
in order to actually recognize it and work through it, because that helps you to grow.
Joy, whatever her name is, Cambridge.
There's
Yeah.
really nothing to do
You know,
but
she's
to
from PSA.
do it.
down in
So,
Oregon.
with,
She's
as the
from
Tao says,
I
wu wei, action through non-action, do nothing and everything will be done. You know this, yeah. So I would say read more of Lao Tzu,
Okay, that's fine.
incorporate that,
It's fairly new, I mean,
and
but see, I don't see what it contributes to
understand
the
that,
discussion.
you know, we are.
Well, that's what I'm not
How we
in
getting.
that tradition of the
Flow.
black psychology,
Grateful.
psychiatry,
And
studies.
things
And so this
happen
was a new
for-
wrinkle in
we can learn from.
the study of black psychology, what
Yeah.
might be
And-
behind some of those
I guess, you know,
Yeah,
maybe,
psychological.
I mean, I have to read it.
So use it as an
I was saying,
opportunity.
I like the model
Yeah,
about that, she says black people
I was
that
trying
are
to,
aware of their But
figure
what,
out
what, where the healing comes in
fast.
is when we join
Don't do that.
together.
Oh, no, no, no,
Oh.
no, very educated, no.
Okay, good.